Good morning. This is group 17, and this is our PDSA on preventing hospital readmissions of pediatric asthma patients. Our group consists of Alex Reyes, myself, Jennifer Kimball, Juliano Querios, Maggie Iglesias, Mia Vasquez, and Wendy Fernandez. So while all changes do not necessarily lead to improvement, all improvements do require change. And the ability to develop, test, and to implement changes is essential for any individual group or organization that wants to continuously improve. For our PDSA, we look to improve a workflow of processes as an important way to improve services for pediatric patients and their families. PDSA is a four-step process, a four-stage problem-solving model that is widely used for improving processes or for carrying out change. Our aim statement, the goal of our PDSA, was to reduce the number of readmissions for asthma exacerbation in the pediatric population by 2% over the next year. For our problem statement, we determined that asthma is considered an ambulatory care sensitive condition, and in the ambulatory care setting, appropriate asthma control and management in conjunction with an asthma action plan as prescribed by the primary care physician or specialist may very well mitigate acute exacerbation and prevent admission or unnecessary readmissions.
A major component in the planned stage of the PDSA cycle includes conducting a root cause analysis. By conducting a root cause analysis, we are able to identify the the basic or causal factors that underlie variations in outcomes. A root cause analysis allows us to identify the root of the problem in a process, including how, where, and why a problem, adverse event, or trend exists. The research conducted by our group during the root cause analysis has helped us to identify the potential problem of why there is a high incidence of hospital readmission for pediatric asthma patients. In a study conducted by Liu and Perlman, findings suggested that differences in healthcare coverage are associated with higher readmission rates for pediatric asthma. Another study found that children with poor access to care has statistically increased readmission risk compared to children with better access. Additional analysis revealed that children with private insurance and good access to care had the lowest rates of readmission within a year compared with other combinations of insurance and access. One tool we have used that proved beneficial during our root cause analysis was the 5 whys technique. We chose the 5 whys technique because it allowed us to repeatedly ask the question why, which helped us to peel away the layers of the symptoms that could lead to the root cause of our problem. Our 5 whys led us to the following questions. Question 1. Why are asthmatic children that are underinsured readmitted to the hospital more than those with better insurance? The answer, because children with less insurance have less access to ambulatory care. Why question number 2? Why do children with less insurance have less access to ambulatory care? The answer is because their parents are less likely to bring them in for routine care. Why question number 3? Why are their parents less likely to bring them in for routine care? And the answer, because of a cost, lack of insurance, and lack of knowledge as to where they could access that care. Why question number 4, why don't parents have a better understanding of where they can access routine care with minimal insurance coverage? And the answer, they are not informed at the time of discharge. And the last why question number 5 is why are they not informed at the time of discharge? And the answer is because of poor discharge planning.
If we provide inpatient family education programs that incorporate multiple strategies, including individualized management strategies and post-discharge follow-up appointments, educate the patient and family about the diagnosis throughout the course of the hospital stay, Ensure that families are prescribed and able to fill recommended asthma medications upon discharge. Conduct a medication education reconciliation prior to discharge. And educate families on self-care. And if we educate on the importance of timely communication with the primary care physician and routine ambulatory care, help at-risk patients and their families, remove environmental barriers to asthma control by strengthening ties to the community, resources using data to measure progress, give the patient and family a written discharge plan and assess understanding of the plan, provide referrals to low-cost community clinics that serve the uninsured population, and if we review what to do if a problem arises, then we will see a 2% reduction in pediatric asthma readmissions.
A better way of doing this type of care would be to create a pediatric asthma care team that would help reduce episodes of acute exacerbation. We can improve discharge plans this way, ensure safe transition to the home environment, and reduce readmissions to the hospital. Every child and their loved ones will receive comprehensive asthma education during the hospital stay from a respiratory therapist, and ensure that families understand how asthma affects the body, how to keep symptoms under control, how to manage triggers and symptoms, and how to use the appropriate medications for this. Part of this would be the PAC team will consist of a pediatric asthma physician advisor, a nurse manager, a charge nurse, a case manager that can do follow-up phone calls to the families in their home, offer consultation services, and also offer an advice line for support, such as Monday through Friday for some extended hours. And some families would need referrals to special clinics to reinforce this type of care. During the hospitalizations, a development plan is essential to identify champion teams, such as the PAC team that we talked about. Develop an awareness of such as a campaign for the staff and families, test the PAC team with mock rounds to just elaborate on different types of scenarios. Offer in-services held with the frontline staff on day and night shifts to discuss, especially to discuss when the rollout of the program will be. Retesting the PAC team with mock rounds will ensure competency and set the date of summer 2016.
And how are you going to measure the success of our plan? So we're going to get information data from the course of 12 months, and we're going to track the readmission of the rates for children aged 1 to 17 that comes back to the hospital, and in the past 30 days they have like asthma as a primary diagnosis, and we hope this readmission rate is going to decrease 2% from the baseline. And we're going to start surveying the families and the parents of those children that has more than 3 readmissions in the last year, and we're going to ask them how the ability of the manage asthma symptoms are improved upon discharge, what causes of access to ambulatory care if it was improved, and if the hospital experience was improved. And surveying then with these questions, we're going to go back to our root cause and see if we are improving those why questions, and hope we're going to decrease the readmission of children with asthma to the hospital.
So one of the ways that we can standardize the plan is that once the data has been reviewed and feedback is given from the PAC team, we can create a standardized asthma care checklist to be initiated upon admission of any asthma patient. So of course, on the initial assessment, we find out what they already know about asthma and what they're doing at home, any barriers, any needs, and any resources the patient and the family are already utilizing.
And second of all, medication reconciliation, find out what the patient has been taking at home, what they've been using to maintain their asthma. And then to also make the appropriate referrals while in the hospital, whether that be with a social worker, a respiratory therapist, or if they do offer any kind of person that can educate them on asthma. And that would go hand in hand with meeting with the family one-on-one. And then prior to discharge, to also set up a hospital discharge appointment with their primary care provider. Another point is to give them their written prescriptions, give them written discharge instructions, and make sure that they will be receiving the proper home equipment, such as a nebulizer, as needed. And then lastly, to also give them information for community resources and support. So then where do we go from there as far as ongoing measurement? So the PAC team will continue to orient the staff and other healthcare providers on the use of the asthma care checklist, gather feedback on the ease of use or any barriers that they have to using it, and then continue to monitor families' consistency in keeping follow-up appointments and their access to care. And that can just be done by a follow-up call, either by another nurse or a social worker, to see how well the family and the patient has been compliant with that. And then finally, to continue to analyze readmission data to monitor the primary causes of pediatric readmissions, and adjust the plan as needed to help ensure adequate patient care within the hospital and after discharge.
So this is the end of our presentation. Here are our reference list, and I hope everybody enjoying watching it, and I hope everybody does well, and good luck to everybody. Thank you so much.
Bye.
Bye.